everybody, welcome once again to AARC's Big Ideas Theater. I'm Ed Highland. Got the honor now of being joined by Richard Branson. Mr. Branson, talking a little bit about the 2017 ATS SCCM guidelines. I want to get all that out of my mouth so I can put it over in your direction so you can tell us a little bit about the guidelines and some of the changes that have been taking place.
So mechanical ventilation is ubiquitous to every ICU, whether you're in the neonatal ICU or the adult ICU, cardiac, head injury, trauma, medical problems. And specifically, this problem of ARDS is a disease that has a mortality rate that still is around 40%. So a group of societies got together and said, let's painstakingly look at everything that's been published and let's really sit down and synthesize the data into evidence so that we can tell people, these are the things you ought to do routinely, these are the things that you ought to do in certain circumstances, and these are things perhaps we've done in the past you should avoid.
Can you give some thoughts on how respiratory therapists can actually put these guidelines to work?
Well, I think respiratory therapists, like all healthcare professionals, need to learn to operate based on best evidence. And best evidence is best care for the patient. And there's too much in healthcare where there have been randomized controlled trials at the cost of millions of dollars to prove something does or does not work, and then at a local hospital, a single person says, oh, I don't believe that. I think this is the best thing. And that's bad practice. It borders on malpractice, but it's bad practice not to do best evidence.
Give us some thoughts on areas where you would like to explore further, areas that are kind of unanswered.
So there's a list of questions. So a priori, when you start with a guideline, you define the questions you're trying to answer so that you can refine the search criteria. But there are still questions about some modes of ventilation. Which one should we use that, quite frankly, there just isn't enough evidence in. And that's a double-edged sword, because you can say, well, this device, the reason we shouldn't use it is there's not enough evidence to prove it. But absence of the evidence doesn't mean there isn't possibly a benefit. And those are the biggest challenges, because there are things that we do on a routine basis that there's not enough data for it to say it's good or it's bad, and we're just kind of stuck at the moment.
It seems like whenever you come up with guidelines or recommendations, there's going to be someone who doesn't agree with them,
for sure,
perhaps cause some controversy. Are there some areas that may be gray at this point?
Well, I think the biggest one for respiratory therapists that's going to be shocking is the high frequency oscillation recommendation, which after two big trials, one in the US and one in Europe, shows that the first trial that was started out of Canada showed that high frequency oscillation not only didn't make outcome better, it made it worse. And this study was done by a group of expert investigators who, up until they did this study, had published a half dozen to a dozen papers saying, hey, this is perhaps the answer to this ARDS problem. But again, when they tested it in a randomized controlled fashion, they proved that it was not helpful. But what that doesn't answer is, what that says is, don't use this initially. It doesn't say if the patient fails the normal treatment, that doesn't mean this might actually be helpful as a rescue therapy. And that's going to be hard for people to wrap their head around.
Well, obviously the more discussion, the more interest, and the more feedback, I guess, you can get as well. Looking at the crystal ball, is there something down the road? I mean, are the guidelines subject to be reviewed?
Yeah, so all guidelines are fluid, and it's actually interesting because this week in the New England Journal, there was a paper published that actually kind of contradicts one of our recommendations. So we had a recommendation. You have to think. So some recommendations, when this is done with an evidence called GRADE, G-R-A-D-E, which is an acronym for the way the evidence is processed. But one of the recommendations was for recruitment maneuvers was, the evidence isn't strong, but it probably doesn't hurt, and it might help. Well, then a paper comes out in New England Journal that says, well, this big trial says it doesn't help. So I bet they'll revisit those guidelines very quickly and perhaps change them.
Stay tuned, as we like to say.
Yep.
Richard Branson, thank you so much for joining us.
Thank you.
I'm Ed Highland. This is the Big Ideas Theater, sponsored by Draeger.